Hi, everybody. My name is Barak, and I want to introduce our moderator and our speaker today. Our moderator is Dr. Pierre Goban. He is the CEO of our sponsor, Serenity Medical, and he's based in the New York City area. He is an interventional neuroradiologist with more than 30 years of experience and is a co-inventor of multiple important medical devices. And Dr. Altschul is also based in the New York area, the tri-state area. Her clinical and research interests include minimally invasive imaging-guided therapies for the treatment of vascular disorders of the brain and spinal cord, such as various types of cerebral aneurysms, arteriovenous malformations or fistulas, dural arteriovenous fistulas, etc. She's trained in Neuroendovascular Surgery in a 2-year clinical fellowship at Columbia, at the Columbia campus of New York Presbyterian. And prior to that, completed a clinical and research fellowship in vascular neurology with a focus on stroke and critical care neurology at the Massachusetts General Hospital and Brigham and Women's Hospital at Harvard and Boston. So just a quick note before we begin. If you don't mind, sometimes people, when they go on Zoom, their Zooms sometimes just say iPhone or say laptop. And of course, if you want to keep it anonymous like that, that's totally fine. But we would love to know who you are. So if you wouldn't mind maybe changing to your name so that we can potentially address you by name. If you feel like you'd like to turn your video on, please do. We want to make this as community feeling and interactive as possible. So please do that, and please interact in the chat, write your questions, and at the end there will be some good Q&A. So with all that, please, Dr. Goban and Dr. Altschul.
So hi, everybody. Thank you for this invitation and introduction. It's really a great pleasure to talk about something that I've been feeling passionate recently about, and that's pulsatile tinnitus. I still remember when I was a resident, and all we did for pulsatile tinnitus workup was a carotid ultrasound, and if that was negative, that was it. And while, carotid stenosis is a cause of pulsatile tinnitus, it's a very, very, very rare one. So pulsatile tinnitus is really a symptom. It is not a condition. So because it is a symptom, people will volunteer this symptom to a lot of different practitioners and access channels, and that may involve, also asking the social media or looking, on online for information. And I think in a lot of ways, the symptom is not normal, but a lot of people are told that this is a normal thing. It can come and go. And however, I do believe that it does require a workup to figure out why someone has a symptom like that. There's a nice paper written by the UCSF group about the causes of pulsatile tinnitus, which they divided into structural causes, metabolic causes, and vascular causes. And so for the purpose of this talk, we're going to be focusing on the vascular causes. And that's because mostly the referral patterns to someone like me, who is a neurointerventionalist, and I'm biased in doing vascular interventions. So usually when people come to me, not always though now, they will have already a workup for structural and metabolic causes. And I do think that everyone should get a comprehensive workup when they do volunteer the symptom of pulsatile tinnitus. So rarely ever anyone walks in and says, "Hi, I have pulsatile tinnitus." This is something that needs to be elicited and asked for. And it turns out that this is a very helpful symptom to elicit different conditions. People may say that they're whooshing or buzzing or ringing and whistling, and it's very important to figure out if this is with the pulse or not. There are about 50 million Americans or so who live with a sound that they hear, a sound that has no external source. And it's usually the kind of constant ringing, because only about 5 to 10% of all the tinnitus is really the pulsatile form. Once they do have a pulsatile tinnitus that is confirmed by a physician, then in about 70% of all cases with a comprehensive examination, we can determine the cause of it, which is really great. So the first thing to distinguish is the noise that they hear in pulse synchronous, or is it just rhythmic? So what can pulse near the ear organ can be arteries, veins, or the cerebrospinal fluid. So these are the fluids that can create a pulsing sound that is heard with the heartbeat, versus a rhythmic sound, and it can be very easily distinguished by asking the patient to tap it out in front of you and asking them if it gets faster or slower with the heartbeat. Rhythmic, there are also rhythmic pulsatile tinnitus. They can be sometimes described as pulse asynchronous, and they're usually spasms of some of the muscles in the middle ear, and also of the soft palate. And I've seen cases of that. It's quite impressive. Sometimes you can even hear the clicking yourself. And the treatment, of course, is not a vascular treatment. So what happens when our pulse becomes audible? And that is the usual cause for that is that there is a turbulence in flow. So somewhere near the ear organ or the lateral transverse sinus, there is an obstruction that causes the non-laminar flow to become turbulent, and therefore it intensifies the sound of that, artery or vein, and the patient can hear it then. And the other part to it is a dehiscence. So that means that there is a thinning or a disappearance of the bony envelope that isolates the sensory organ from the surrounding fluids. And there you don't need to necessarily have an obstruction. That will lead to an increased perception of a normal pulsation. So how do we assess for pulsatile tinnitus? So a lot of it can be assessed by clinical examination and history. So we ask for onset, whether it has progressed, and how severe it is. I used tinnitus handicap inventory, which you see here on the right, which is a very useful tool to monitor progression. And hasn't been developed for pulsatile tinnitus per se, but it really helps to sort of figure out in a more objective way how bothered the patients are by the pulsatile tinnitus, because not everyone is bothered, but so you can assess it also longitudinally. And typical a score of about 38 or higher is considered a moderate handicap or higher. Some factors that can alleviate or exacerbate the pulsatile tinnitus, as you know, most people don't hear it all the time because ambient noise will make it go away. And they complain frequently about it when they're falling asleep. There are certain head positions that they can take on that may cause the pulsatile tinnitus to either go away or get worse. Also, people can say that they only hear it when they bend their head forward. All of these are important factors to figure out, but the most important one is probably to figure out whether the patient himself or herself can actually alleviate the symptoms by finding a spot in the neck or on the head where then when they compress, the noise goes away. And then there's a list of medications that can be associated with pulsatile tinnitus. Some of these medications can cause IIH, idiopathic intracranial hypertension, and that can bring out a pulsatile tinnitus. And other medications are causing damage to the ear organ itself. And in those cases, often the pulsatile tinnitus is not really pulse synchronous, but rather a tinnitus with pauses. So it may appear like it is a vascular cause. It is good to ask for associated symptoms, such as if there's any headache or head and neck pain and injuries to the neck, any vision changes that they can report, blurry vision or changes with vision when they put their head down, different sort of almost like migrainous visual symptoms that they can get, vertigo or dizziness, if there's any association with that. Is there any sort of signs of anxiety or depression, either as a consequence of the pulsatile tinnitus or because there was a pre-existing history? And then I also ask always for stroke symptoms, if there were any recently. And then additional sort of autologic considerations, hearing loss, if they had any prior ear surgery. Frequent ear infections can be associated with dural arteriovenous fistulas, ear pain or drainage. Most of these things, when they come from the ENT, have been already evaluated. But if they find you for the web or other source, it's good to perhaps ask for these things. Autophony, which is the hearing your own voice at a higher level, more intense, or sounds in general more intense. Oral pressure is when you feel fullness of the ears, very common description by the patients. And then sound-induced vertigo, which is a very rare symptom. And particularly the last three symptoms, they can be associated with a superior semicircular canal dehiscence, which is shown here on the right, where the bony overlay over the semicanal is missing. And these people probably hear the CSF pulsations, and that's why they have a pulsatile tinnitus. And this is usually fixed with surgery at this point. If they do see an ENT, they usually do get a full otoscopic examination, looking for anything obstructing in the ear canal, middle ear fluid, cholesteatomas, and then tympanic paragangliomas, glomus tumors. You can see here on the right side of a bulging mass behind the tympanic membrane. Everyone will get an audiology examination, where they basically test for air and bone conduction thresholds to distinguish a conductive versus a sensory neural hearing loss. Now, in pulsatile tinnitus, usually there is no hearing loss per se. It just may mask, the pulsing may mask the sounds, but you couldn't fit it into a picture of a sensory neural and conductive hearing loss. However, by performing these sets of tests, the ENT will get an idea as to whether he needs to do any follow-up examinations. So they will look for, tumors of the cerebellopontine angle, if there's sensory neural deficits, or if there's conductive hearing loss, they will look more closely on the middle ear, where there is any autospongiosis or other things. So having this information, I think, is important, because sometimes people will have multiple reasons for pulsatile tinnitus. Phonoscopic examination. So if there's a suspected intracranial hypertension, a sixth nerve palsy, an exacerbated headache when they're lying flat, sleep apnea, obesity, or morning worsening of the pulsatile tinnitus, it is helpful to do a phonoscopic examination. However, it is sort of somewhat limited by bedside testing, as we do not dilate usually the pupils. And you can see here It's a grade 3 papilledema. You can see that the rim is only preserved here medial temporal, and then it's blurred all over the rest of the optic nerve. Quite honestly, it's quite a subtle sign. And if I do suspect someone to have IIH, I always send them for a full neuro-ophthalmological examination. And I know that on IIH Hub, we had some wonderful neuro-ophthalmological discussions and informations as well. Pulsatile tinnitus is one of those areas in medicine where having a stethoscope is actually still really, really helpful. I keep joking with the cardiologists if they ever listen to the heart anymore. But meanwhile, I do have one myself. And so here are the points that I routinely listen to people. Because there is the distinguishing factor of objective pulsatile tinnitus, meaning that I can actually hear it. That could be over the neck, which suggests, of course, a carotid issue, or over the cranium itself, which is usually can be elicited with dural AV fistulas. And there have been multiple occasions where I have diagnosed a fistula just by listening myself. And subjective pulsatile tinnitus is something that only the patient hears and you don't hear it, but that doesn't mean that the pulsatile tinnitus is not vascular, and it's usually associated with more venous causes. A very helpful examination is to compress the jugular vein during the exam. And I do this all the time. I like to compress it right here, where the jugular vein comes out of the bone. It's very easily compressible. And when the patient does have a noise during the examination and you compress it ipsilateral to the noise goes away, then this is a very strong suggestion that you're dealing with a venous cause of the pulsatile tinnitus. This is actually incredibly helpful in the whole process of treating pulsatile tinnitus. So what happens, you close off the jugular vein here, and instead of the venous blood being cleared through the ipsilateral transverse sigmoid sinus, it goes more towards the other side, and the patient stops hearing and the pulsatile tinnitus. And so the other helpful tool is occipital artery compression. So often these people have a bruit on the examination, and then if you compress it back here, the noise will go away. That's more of a suggestion of an arterial cause. And then patients can report to you, or you can ask patients if head turning makes a difference to their pulsatile tinnitus. So overall, higher pitched pulsatile tinnitus heard over a dural sinus, sometimes even CC fistulas can be heard, points to it's more of a dual arteriovenous, more of an arterial cause, if you so will. And when I go around talking about it, I always say, you know, the physician hearing a noise over the cranium, that's like an automatic referral to a neurointerventionalist. And or on the flip side, you have a lower pitched pulse synchronous hum that's improving with jugular compression, and that suggests more of a venous cause. So at the end of your examination and history, you should have an idea whether it's a pulse synchronous or a pulse asynchronous pulsatile tinnitus. The pitch, is it lower pitched, often venous, higher pitched, frequently arterial, or very high pitched with pauses, less likely vascular? Is it unilateral or bilateral? And is it subjective or objective? And then if it resolves or is reinforced, not changed with ipsilateral jugular compression. And so to characterize the different forms of pulsatile tinnitus, we have the arterial form, we have the venous form, and then we have a pulsatile tinnitus that is completely neutral. It doesn't appear to be compressible, or is not, it doesn't have a bruit, and that's something that we can call neutral pulsatile tinnitus, because I believe that's the neutral pulsatile tinnitus where we still have a hard time figuring out why exactly the patient has a pulsatile tinnitus to begin with, and these are the ones to know going into any type of treatment. Non-invasive imaging protocols, actually there's a nice paper by Cummins sort of detailing the different imaging protocols. Usually very helpful is an MRI brain with and without gadolinium that rules out all structural, arterial, and also radiographic signs of IIH. An MRI brain with 3D time of flight is helpful to look for any AVMs or AVFs. And then an MRI of the carotids to look for carotid dissections, FMD, and carotid stenosis. And then usually some of those images were already completed by the time they see me. But interestingly enough, an MRV is typically not a standard sort of evaluation. That's something that is sort of added extra. And I often order that in addition. And then if any of the above doesn't show any cause, then a CT temporal bone should be obtained. And if anyone has a contraindication to MRI, then you can use a CTA brain and CTA with delayed phase, venous phase. Interestingly enough, in one study by Tao, just published last year, they had 187 patients and 51 of them received a diagnosis of vascular pulsatile tinnitus or a diagnosis of a cause of pulsatile tinnitus exclusive with non-invasive testing. But an additional 21% received it when an angiogram was performed. And that's about 70%, which makes sense of what we know about the causes of pulsatile tinnitus. So what are the most common etiologies? So for vascular tinnitus, the most common etiology by far are venous etiologies. There are more than 50% of all the causes. And within the venous etiologies, it's IIH syndrome and dural sinus stenosis, the number one leading cause, which I will be spending the most time talking about. We have dehiscence of the sigmoid sinus and diverticular of the sigmoid sinus, which I will touch on, and jugular bulb abnormalities, mastoid emissary veins, and sort of a sequelae of sinus thrombosis, all associated with a venous pulsatile tinnitus. Now we have arterial causes, which is skull-based vascular tumors, like those glomus tumors. They can cause pulsatile tinnitus, usually when they're right next to the hypoglossal canal, and jugular foramen, cervical carotid dissections, and stenosis or FMD, intracranial vascular malformations, anemia and thyrotoxicosis, and vitamin B6 hypervitaminosis. I've seen those in clinical practice. They can be independent, or sometimes they can bring out a sort of underlying issue when people have these conditions. So I usually still proceed with a workup even if they have anemia. And other causes can be suprasemicircular the semicanal dehiscence that I already touched on, and otospongia. Usually these things are taken care of by ENTs and we don't see them.
I have a question, Dorothea, from the audience about the ENT evaluation. How important is it? And will any anomaly of structural anomalies of the ear be visible on MRI or CT?
So it depends on what kind of a pulsatile tinnitus we're dealing with, right? If we have a venous pulsatile tinnitus, I believe that having an evaluation by an ENT can be helpful to look for bony abnormalities and conductive hearing loss. If we have an arterial, it's usually less helpful. And if you have a neutral cause, then I think a close collaboration with an ENT is helpful to understand if they're seeing something that could be associated with the pulsatile tinnitus. In terms of ear abnormalities, I do believe that a CT, thin cuts, temporal bone, is the better imaging modality to obtain to evaluate it for a sort of ear abnormalities. I hope that answers the question.
Thank you.
Transverse sigmoid stenosis or dural sinus stenosis, the number one cause for venous pulsatile tinnitus, and what I'm seeing in my practice. And MRV, as I said before, is a wonderful tool to see a sinus stenosis, particularly if it's gadolinium enhanced. However, not everyone will get an MRV, and most importantly, in non-academic settings, these MRVs are often not reported correctly. So if there is one cause where, as a neurointerventionist, you can contribute to the evaluation of a patient with pulsatile tinnitus, is by reviewing the transverse sigmoid sinus. Often a MRV is not necessary because on the coronal views, on the left side, you see a normal transverse sigmoid sinus junction with a triangular shaped structure. And on the right side, you see a compressed one, which is, best seen on the coronal gadolinium enhanced pictures. It's important to pay attention to the type of transverse sigmoid stenosis. So there are extrinsic ones, which you can see on the left side, where there's sort of compression of the transverse sinus, transverse sigmoid sinus, the upper part of the sigmoid sinus, usually due to compression of the brain and due to high ICP, but also could be because there's a weakness in the wall of the transverse sinus. And then we have intrinsic, which we can see in the middle, which are feeling defects inside the transverse sinus, usually by proliferated arachnoid granulations or CSF cysts. And then on the right side, you can see something that is sort of could be either. Often hard to say from just a transverse, from just an angiogram, but that all it looks like it's that there's turbulent flow for sure. And this was actually someone with a temporal encephalocele that caused these turbulences. There was no sinus thrombosis, even though I think it could be misconstrued for that. So again, as I said, extrinsic venous compressions, you can see more of a longer segment is here evaluated by an angiogram. And the reason being is that the transverse sinus in particular has been shown to be most susceptible to extramural pressure on the transverse sinus. And there are other spots as well, for example, the distal third of the superior sagittal sinus. And the sigmoid sinus is more resistant, as is the torcular, to external compression. And here you have some example of intrinsic obstructions. It's a little proliferated arachnoid cysts, and actually one of them is arachnoid granulations on the left one here. This was actually an arachnoid cyst that caused pulsatile tinnitus. And another thing to pay attention to is the venous outflow laterality, which I cannot sort of emphasize enough. So most people will have a slightly right dominant outflow, and usually pulsatile tinnitus is associated with the more dominant sinus. However, that is not always true, because here you see in the middle, you see someone with a more right dominant transverse sinus, however, had a left pulsatile tinnitus and the left-sided stenosis. And then when we do have bilateral, either codominant transverse sinuses with bilateral stenosis, that's when we have to think about IIH. And that can be also happening in someone who has an aplastic or hypoplastic sinus on one side, and then a stenosis on the other side. But in any case, both transverse sigmoid sinuses should be somehow impaired for the pressure to rise. As you know, and for this audience, probably not a surprise, but the criteria for IIH diagnosis are from 2013. They're quite old. They're quite strict. You know, you have to have papillary edema, normal neurological examination, normal CSF composition, and then elevated pressures above 250. And they still talk about pseudotumor, which we know is an outdated term at this point because it has nothing to do with tumor. But they do acknowledge that there's a syndrome that does not have papillary edema, but it can be only suggested, not really diagnosed according to this criteria. And it can be suggested if you have 3 of these radiographic signs: empty cellular flattening of the posterior aspect of the globe, distension of the perioptic space, and transverse venous sinus stenosis. So, however, there is a lot of other radiographic signs that can also be associated with IIH. And for example, aberrant arachnoid granulations, usually seen in the sphenoid wing, flat out brain herniations into arachnoid granulations, carry-1 malformations, or encephalocele. And I think it's important to know, because people who decompress themselves like that, their ICP may go down, and then they may not develop actually papillary edema and the full syndrome to really qualify for a diagnosis. But that doesn't mean that they don't have the disease. We know here, I think, that this is a spectrum of diagnosis. We can have no symptoms and just radiographic findings. And then on the other side, we can have all the radiographic findings, papillary edema, high ICP, and all the hallmark symptoms. That in 70% includes pulsatile tinnitus. And in fact, you know, eye doctors, when they see papillary edema, they will ask for pulsatile tinnitus to distinguish it from other causes, and they will think about IIH then. And I feel that neurologists, when they have someone with migraine, should be asking for pulsatile tinnitus, as this may point them towards a diagnosis of IIH. And this is thanks and adapted from Dr. Higgins in the UK, which I love. And this is probably the key slide of my entire presentation. So at the very top of the pyramid are the patients, they fit the dandy criteria of the IIH, and they have all the symptoms and the papillary edema, and everyone agrees that they have IIH. But then underneath that, there are these people that are called IIH WAP, IIH without papillary edema, and they have a higher ICP, but they do not have the papillary edema. And so sometimes it's difficult to convince people that they also have the disease if they don't fit all this criteria. And then underneath that are these people who have not quite IIH. So the ICP is not quite normal. It's not less than 20, and they may have some radiographic signs or not. But what is key to realize in this group is that anywhere in the spectrum, they can have pulsatile tinnitus, and anywhere in the spectrum, therefore, they can have a symptomatic transverse sinus stenosis. So when we think about this disease, we think of them of moving along the spectrum here. So what is a significant stenosis, and how do we evaluate that? It's not always easy to measure a stenosis. I think, therefore, a lot of people do not get the appropriate evaluations. Sometimes it's more clear, and other times it's less clear. But I do have sometimes a hard time myself in what view and how to diagnose this. I try to use this quantitative program to tell it to myself, which is helpful. But I think what I want people to realize is that the transverse sinus does not correlate to a cylindrical tube. And it has been shown that after a stenosis of around 35%, which is not a lot, it has already a significant higher gradient. And so therefore, stenosis that are not looking as bad may have a significant gradient. So how do we distinguish then whether these stenosis are significant? I think where it is very helpful is to do venous manometry. So I routinely do this on all patients. I will put my catheter all the way into the superior sagittal sinus, usually the sort of mid to anterior third. And there are studies out there that showed that sinus pressure correlates with an opening pressure on LP. And I usually find that in normal people, it will read somewhere between 15 and 18 millimeter mercury. Don't forget that you do have to convert it into centimeter water to correlate it to the opening pressure. But there are studies out there that correlate it to EVDs and other things. So this is a good idea to get an idea if the pressure is normal or not. And then I do measure it all the way down to the C1 level for anyone who presents with a venous pulsatile tinnitus. Sometimes I also go through the other side if there is a connection through the torcular. Otherwise, I will go ipsy from the other side. I do measure everything. A normal total gradient is definitely less than 6. It may be less than 4. I don't know that we have data to be certain. But the total cranial gradient is the gradient measured from the supraoccipital sinus down to the jugular vein. Versus some papers will talk about transstenotic gradient, and they talk about a gradient from the torcular to the sigmoid sinus across a stenosis, which is very different. So in IIH patient, when starting to stent them, usually I use the gradient of more than 8 millimeter mercury. However, in a pulsatile tinnitus situation, when the gradient across the stenosis can be much smaller and still lead to significant symptoms. So in this one paper by Atos, he used 42 patients with exclusively isolated pulsatile tinnitus, so IIH patients were excluded, and the transstenotic gradient was 4 or greater, with 39 patients receiving complete resolution of the pulsatile tinnitus after stenting.
Dorothea, we have a technical question from the audience.
Mm-hmm.
What setup do you use to measure pressure? What microcatheter and what transducer?
Yeah, I would get to that in just a second. Okay. And then this is actually from a paper from Professor Houdart in France, and he uses under general anesthesia a pressure gradient of 3 as a significant measure. He is also the one who has found that perhaps in addition to pressure gradients, the velocity matters. So the velocity for stenosis can speed up to more than 10 times through the narrowing. And in one of the papers where he looked retrospectively, he found that if you only select patients by gradient, you will miss 24 patients. And so it is a possibility that measuring the velocity in the future will be an additional tool that we could use to find the patient that will benefit most from stenting. So yeah, so the solution to the problem is a venous stent, but I just wanted to go over the fact that general anesthesia, if you measure the venous gradient under general anesthesia, you actually lessen the gradient, because what we can see is that the pressures in the jugular vein and sigmoid sinus go up, and therefore the gradient across the stenosis may diminish. And there are other factors that can contribute, such as microcatheter size, medications, whether they're already on some medical therapy for IIH, a recent lumbar puncture, for example, and tidal volume should be kept pretty constant. And then mean arterial pressure should be kept within 20 millimeter of mercury. So I think that pressures can be measured, but and there was a paper to that extent that that argued that you could do it under general anesthesia, but you have to be aware of these limitations. So what is sort of the indication for venous sinus stenting for symptomatic stenosis? So definitely pulsatile tinnitus with medically intractable IIH. I think no one will argue about that. But in my practice, increasingly females who have pulsatile tinnitus, and they are otherwise well controlled in terms of their papillary edema, but they have a desire to discontinue the Diamox or the medical therapy because they wish to become pregnant, and Diamox is teratogenic. So I have actually quite a few patients like that. And then, of course, if you have a debilitating venous pulsatile tinnitus, then that's another indication. The debilitating venous pulsatile tinnitus, I usually take as a handicap, a measure of 38 or greater, stenosis and the transstenotic gradient of 4 or greater. If all that aligns, then they're a good candidate. The pre-procedural steps are usually that they either come already from an ENT evaluation, and they usually have all the MRIs completed. And sometimes, if I suspect IIH, they get an ophthalmological evaluation and an MRV of the brain before the procedure. But then I do a diagnostic angiogram with a transstenotic gradient and intracranial sinus pressures. Everyone gets that, just in case we're missing any IIH. And then I do, at the same time, a DynaCT with thin cuts for the temporal bone. So what does a diagnostic angiographic workup include? It includes a cerebral arterial angiogram with measurements of the stenosis. It includes pressure measurements across the stenosis and all the way up to the suprasagittal sinus to measure the pressures to correlate with an opening pressure. A cervical angiogram to look for any sort of jugular compressions. And then this DynaCT, which I love because it's much nicer than a CT of the temporal lobe, in my opinion. And I usually look here for sigmoid dehiscence, any diverticular jugular bulb abnormalities. It's really very helpful to evaluate the patient. And then once this is all complete, then they will be, they will offer their stent. And now this is maybe a little bit controversial, but this is definitely an area where it's in progress and changing. But I have started all my patients to have a hypercoagulable workup because, sinus thrombosis is a thing. And while it is a very unlikely thing, in people of less than 40 years of age, let's stand aside, if they do have a venous thromboembolic event, more than 50% of them have an acquired or hereditary hypercoagulable disorder. And so therefore, because this field is starting, I don't want any of my patients maybe in the future have any issues with the stent. So all of them get a hypercoagulable workup, and which I order. And if it's negative, then we go ahead with the stent. If it's positive, they see a hematologist. They get started on dual antiplatelet, and I'm happy to discuss this. I know this is probably not standard, and the hematologists do not like me for that. Dual antiplatelet therapy 1 week before, and then 3 months for 3 months after, at which time they get a CT venogram, and if everything looks okay, that gets discontinued. They usually get a radial artery common femoral vein access, although some people do it through the brachial vein, and they usually get booked for a 23-hour stay. They get the Gorn sheath, that's 8 French, and I use the Armadillo 95 centimeter with a 180 centimeter teruma that I get all the way into the sigmoid sinus and sometimes through the stenosis, depending on how it looks like. This catheter comes in support mode and in tracking mode, and I love it. I think it's the best to deliver these stents. I use a microcatheter at Phenon 27 or Zoom 35. This is also what I use to measure my pressures. And if I measure the pressure separately, not through the armadillo, then I use an Envoy. You need to use a 5 French Envoy. It's very simple. You put it here, and then you can go with a 27 catheter and just a regular soft wire. It is, you should use at least a 27 catheter so you get the most accurate pressures that I measure through the A-line. But, you know, I'm sure there are other ways of measuring. The most important thing is to have the transducer at the head level. If it's lower or above, you get wrong measurements. And I preload the stent on a treasure with a treasure exchange wire, and I almost exclusively use silver stents because of their longer lengths. And so this is just an excerpt of a stenosis, and that gets stented. In IIH patient, I think it's really important to stent all the way to the torculum. If you don't, and you leave some of the transverse sinus exposed, when the disease do come back, it could come back in the future. You will see that you will find yourself restenting that segment. And sometimes, you know, we do need stent constructs. Then I just telescope the stents in, and occasionally you will need to angioplasty the stent because it won't open all the way, probably to some dural sleeves or folds inside. However, that is quite rare. This is probably the largest series of 200 patients that received dural sinus stenting. And you can see here we have pulsatile tinnitus at baseline in those patients at 84%. And then the resolution rate was 81% after the stent went in, with 4% having partial improvement or no improvement, and a 15% recurrence. So I think venous sinus stenting works really well for pulsatile tinnitus, and this is consistent with what we have seen in other studies. In terms of complications, so in this particular study, there were 42 patients who had post-stent headaches. And here I would say that when I first started to do stents, I used to stent like I would a carotid artery and oversize the stent. But now I really dramatically undersized the stent. And ever since I started doing that, so at least a millimeter, if it measures 7, you take a 6. If it measures 8, you take a 7 stent in diameter. And always err on the side of smaller. Because when they're larger, I think they get like a headache that's sort of on the brow up here and on the back. And ever since I started to undersize, it works just as well, and the patients don't have that headache. You know, groin hematomas, I don't know, for me, this is like some sloppy technique, but that's reported. And then that's the stent thrombosis. You can see 1%, so very, very rare event, epistaxis, and then some other things that are probably not related.
Dr. Altschul, sorry to interrupt, but we should quickly move to Q&A if people have some questions that we want to ask you. Are you very close? Can we kind of come to a bit of a landing? So, because people really want to ask you some things.
Yeah, well, if there's a burning desire to ask question, why don't we ask question now, and then I can continue afterwards.
Yeah, just because we want to people have blocked off sometimes, but some of them also need to get back to work. Sue Bornman, do you want to come on camera and ask? You have a couple of questions. Would you like to do that? or I can ask for you. One of her questions was, is there a working group developing an updated criteria for IIH diagnosis, either with or without papilledema?
I don't know. I'm not aware of one. I wish there was.
Yeah, it's 10 years. And another one, if someone doesn't have MRA or CTA but gets the MRV and CTV, could something have been missed or overlooked?
CTV. It depends. If they have a venous pulsatile tinnitus, probably not. But I'm a big advocate of having a complete and a comprehensive evaluation, because the longer I'm doing it, the more I find that there are multiple reasons. And in one patient, they can have multiple conditions that cause the pulsatile tinnitus.
Okay. Dr. Ferreira from Portugal, would you like to come on camera and ask for Dr. Altschul's opinions that you wrote in the chat?
Hello. I don't
Obrigado.
Thank you very much. Sorry, I don't know if you can hear me well. Can you?
Yes, we can.
Oh, thanks for the great talk. So I just put it on the chat. Some questions I had are really quite practical questions. So the first one was, how far would you go on the workup of patients with a pulsatile tinnitus, only a pulsatile tinnitus? Would you consider to do angiography, digital subtraction angiography on every one of them? And the second one is almost a case I recently have, because it's a patient, a 14 years old patient with a cerebral venous thrombosis and a pulsatile tinnitus that was developed during the headache. And he had mild intracranial hypertension symptoms, and his MRA was negative for a AV fistula. We were just discussing this case recently, if this phenomenon would be due to an underdiagnosed AV fistula and we should proceed to DCA, or if it could be just like a flow diversion phenomenon from the venous drainage blood. I don't know if I make myself understand.
So yes, so it is a well-known fact that sinus thrombosis can cause pulsatile tinnitus, particularly if it involves the transverse sinuses. And because they sort of get a secondary increased intracranial pressures. And so I always treat them medically with Diamox. I have not stented someone with a sinus thrombosis, but that's mostly because I'm afraid at putting, a stent into someone who had a sinus thrombosis. However, often they can find some resolution when they're treated with anticoagulation. So I see pulsatile tinnitus often in acute stages. And then as the sinus thrombosis resolves, they actually get better as well. So you don't need to do anything. But yeah, that's a well-known thing. So they have sort of like a secondary IIH. That's what they have, and that's how they have the pulsatile tinnitus. And what was the first question again?
The first question was, how far would you go on the diagnosis of a pulsatile tinnitus if you do angiography in all of them? So just to let me see if I understand. So you believe that the pulsatile tinnitus in a CVT could be only due to a flow diversion of the venous drainage, right?
Yes.
Okay. Thank you very much.
And
I have another question. On internal jugular vein stenosis, how often do you find it the cause of a pulsatile tinnitus? And if a patient has both transverse sinus stenosis and internal jugular vein stenosis, how do you decide which one to treat?
So I believe it's the transverse sinus stenosis. So, but it does, so this is the first one that you should treat. And if that does not cause a resolution of the symptoms, then you look further. But it is very important to realize that there needs to be some sort of turbulent flow that's close to the, lateral sinus in order to cause the noise. And it's really usually a transverse sinus stenosis, maybe with a diverticulum or a dehiscence. So to understand the sort of bony structure around it, I think is very important. And and so that would definitely be my first approach. And I wouldn't jugular vein compression is often a structural problem. So when you look at it, and that's when these DynaCTs come handy, is it's usually around C1 where it occurs, and you have a styloid process that's sometimes elongated with a lateral sort of protuberance of C1, and they sort of come together. And those, I don't feel like, if that's the case, stents is not a good solution for that. And so one thing to look at if you have jugular compression is to understand what bony landmarks are in that area.
Okay. Another question about the impact of medication on the pressure gradient. Do you recommend that before performing the angiogram, the patient discontinue their Diamox or topiramate?
So usually I used to do that, but now that I've gotten more confident, so if they have pulsatile tinnitus, they have IIH, and they already have the diagnosis, and we are now looking for surgical treatment, then I'm so confident in the clinical abilities that I don't think I've ever missed anyone's gradient just because they were on Diamox, because it's the whole gestalt of the whole disease that will make me, stent it anyways. So I think this is where I have evolved to.
Thank you. I have some question about diagnostic also. How much should you do? Would you do a cerebral angiogram in front of any pulsatile tinnitus?
So of course if we have an arterial pulsatile tinnitus, usually they come with some sort of non-invasive imaging that suggests something, right? And even if it's not reported upon careful examination, you can see a fistula. You can see all these from non-invasive images. So these people for sure get an angiogram, right? So then the next thing is the venous pulsatile tinnitus. Venous pulsatile tinnitus, in my practice, I have really two groups. One group is already diagnosed IIH. Everyone knows that papillary edema, they're here for surgical intervention. Pretty straightforward. But there's a larger group that I'm seeing who has just pulsatile tinnitus, and they have the venous, the compressible sort of the sound goes away with ipsilateral compression. And those I will take to angiogram, and that may be controversial because I give them a full workup. During angiogram, this is my tool. I will measure the pressures, so that then I don't need to like beg someone for an LP. I will do the arterial evaluation to double check. I will do the venous gradients, and I will also do the DynaCT, which is my CT temporal bone. And then I can see, for any sort of sigmoid dehiscences or anything like that. So this is sort of my package that I do as an evaluation. And based upon then I can have a discussion. You need to see maybe an ENT, you need a stent. this was what I found. I think your pressures were not normal. So you may be someone who is on the spectrum. If you gain weight, you may be developing IIH later. If you lose weight, you may be fixing this on your own. Then I have all the necessary information to have an informed discussion with the patient. This is just the way I do it. I don't know that there's any data to support that.
Okay, so it's really a personal, you adapt your workup really to each individual situation, and it's guided by your clinical acumen. Another question about stent-associated headaches. We know that the stents that we use now for venous sinus stentings are arterial stents that have too much radial force. And many patients will develop headaches. So their headaches from the IIH will be gone, but they will develop a localized headache where the stent is. And we have a question from a colleague about a patient which this new headaches, post-stent headaches, is continuing. Do you have any suggestions to how to treat this patient? Maybe a short course of steroids?
No, I like to stay away from steroids because, well, it depends. But so here's the thing. A lot of these patients come in with a headache. They already have headaches to begin with. And so I don't necessarily believe that it's the stent causing the headache, rather than the stent not fixing the headache, okay? So again, if you undersize the stent, you will stop seeing the stent-associated headaches here in the back and up front. It's just going to be greatly diminished. So that maybe was a thing in the past. But I think the problem that I'm seeing is that there is a headache syndrome that, at least in IH, that comes with it, that responds the least to the stent. So we can fix the pulsatile tinnitus, we can fix the pupil edema, but the headaches is something that I find is very hard to fix with the stent. And I don't know that I have a good solution for that. But I don't like steroids because steroids, when you come off of it, afterwards also increase the pressures. And sometimes while people feel great when they're on it, the moment they're off it, they say, my headache is bad, I'm feeling bad. And then you're kind of, and then you think, oh, so now you have to do another course. And it becomes like this, like, I feel great when I'm on steroids, I feel bad when I'm off steroids. And so I try to avoid this. I have recently started to use the newer migraine medicines, the monoclonal antibodies for these type of patients, which I think works really well. So that's where I go with this.
Hi, everyone. We are coming on our time. It's coming 5 o'clock on the East Coast, and we have a number of people from farther east in Europe, Africa, and so we want to be respectful of everyone's time and close off. I want to thank you, Dr. Altschul, so much, and Dr. Goban so much, and just give you a couple final resources and an invitation. So next Friday, December 1st, so quite soon, we have another event, IIH and Pregnancy with Dr. Nicole Plenty. She is an OBGYN and maternal fetal medicine physician. And that's quite early. That's 10 o'clock East Coast time, 7 o'clock for those of us in California. We hope to see you there. Just a couple resources. Dr. Altschul's blog at Neurosurgeons of New Jersey. She has a post specifically on pulsatile tinnitus, and it is a very well-read, popular blog post. So please do check that out, as well as her Instagram at Dr. Altschul. A couple other resources. IIH Hub is a wonderful resource for all of you. There's both a patient section as well as a physician section. And in the physician section, you will find all of our past talks that you can find and watch them in entirety and learn about new ones and sign up for new ones. And finally, our YouTube channel has a ton of really, really popular videos, both aimed at both patients as well as physicians. So please give that a look. That's IIH Hub on YouTube. So thank you so much, and we hope very much to see you next time on December 1st. Thank you.